Okay, good job. So we did our initial settings, we did our alarms, and now we put the patient on the ventilator. Now, obviously, at this point, you should be assessing your patient, their breath sounds, their vitals, etc., etc. If the patient has been intubated and ventilated for a while and you're receiving them at this state, you should be checking the ET tube size and position, the patient's mental status, those kind of things, looking at the x-ray. But of course, with this little ventilator simulator, I don't really have any of that kind of stuff. I mean, they give me some vitals, but we can really only look at what's on the vent for the purpose of this video. So there's a lot of stuff going on the screen, but we are first going to break it down by numbers that we can look at. Then we're going to go with the waveforms. So for the numbers you want to look at, you want to be looking at inhaled and exhaled tidal volume, which here you go to monitoring and it will give you all of your numbers, right? So you want to be looking at your inhaled and exhaled tidal volume. You want to be looking at your minute volume. You want to be looking at your peak pressure. You want to be looking at your dynamic compliance, which I actually don't see here. That's weird. It's giving me all sorts of stuff, but it's not giving me dynamic compliance. Whatever. Tangent. Anyway, if you can see end tidal CO2, you should be looking at your end tidal CO2 numbers as well, which is here. Here's your actual pressure, end tidal CO2. And then typically on a ventilator, you then want to get your plateau pressure, your driving pressure, and your static compliance. Now, typically, for this, you would have to do an inspiratory hold. That will give you a plateau pressure. And then you have to do an expiratory hold, which is then going to give you your total PEEP, which is your PEEP plus your auto PEEP, basically. Somehow, this Hamilton on volume control with a square waveform is somehow able to automatically measure a plateau and a driving pressure. Now, I don't know how that's even physically possible. But anyway, another tangent. The point is, normally you have to do your inspiratory and expiratory hold in order to get your plateau and your driving pressure. The fact that this, and now I don't know, maybe it is able to somehow do that, but how you're able to get a plateau without an inspiratory pause, I have no idea, but somehow this is doing it. Now, the other thing too here is your peak and your plat are going to tell you a lot about airway resistance, but the peak by itself doesn't really tell you much. And a high peak is only dangerous in the context of a high plateau pressure and a high driving pressure. By itself, it really doesn't mean much of anything. Now, a quick note here, once again, this is a simulation with a patient that has no active inspiratory effort, right? If you have a patient who is actively breathing on spontaneous mode or triggering breaths over the set rate on an AC mode, then what's going to happen is it's going to be very difficult, if not impossible, to get accurate total PEEP, plateau, static, compliance, and driving pressure measurements. Now, why? Well, when you do an inspiratory or expiratory hold, the ventilator is stopping all flow of gas at the end of either inspiration or expiration and measuring how much pressure there is within the system. If your patient's respiratory muscles are actively engaging, that will alter the pressure within the system during those holds and therefore change the numbers that the vents are picking up. In simple terms, an actively breathing patient means you can't get accurate pressures. Once again, there's no point during this in which flow is stopping. I don't know how we are getting a plateau pressure. I don't understand how that's possible. I don't know, somehow it's doing it. But anyway, let's talk about waveforms now. So I'm not going to go crazy in depth into waveforms in this video. I'm going to make a future video about that. But just understand that looking at waveforms here, this is looking, these right here, these four things, and honestly, I'm going to simplify this layout. Yeah, I'm going to do that, simplify it, get the heart thing out of there. This is all one breath happening at the same time. This is just looking at four different things in the breath. And really, most vents you're probably only going to have up here the end tidal. Unfortunately, a lot of places don't use end tidal. They should, but a lot of places don't. But this is looking at the same breath through a few different angles. Now you have your pressure waveform here, your flow waveform here, and your volume waveform here. Now, as far as looking at data from these things, our flow waveform is going to be the most valuable. It's going to give us the most information about the patient. The pressure waveform is going to give us a bit of information about the patient. Not the most helpful, but like it can tell us a little bit. And then the volume waveform is only useful in looking at some kind of expiratory leak. That's really, really honestly the only thing it's good at. Once again, like looking at this flow waveform, I'm not going to go into the specific characteristics of different flow patterns, because that does change things a little bit. That's for later. But at the very least, if nothing else, I want you to look at expiratory flow. So this is flow going, so basically here we have flow going into the patient constantly, and then they start to exhale, and they exhale really fast, and they slowly exhale all of it, right? And as that constant flow is being delivered, the pressure increases, right? The flow creates a pressure, and that pressure in the lungs increases and increases and increases, and that delivers a volume which goes up and up and up and up, right? That's what's going on here. And then we exhale, and the volume goes down, 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 back to baseline. You see how the expiratory flow right here is always returning back to baseline at the end of the breath. That means the patient is fully exhaling with each breath. We can expect our set PEEP to be the same as our total PEEP or our auto PEEP, because everything is getting back out of the lungs except for the PEEP that we want to be in there. If the expiratory flow doesn't reach baseline, which I'll change some things and make the expiratory flow not return to baseline. Let's also do this, just for dramatic effect. That should be enough to make it happen. Yeah, a little bit. This is not the best example, but you see that? You see how it's not getting up to baseline? That right there is flow that is still trapped within the patient's lungs. That flow fills a certain amount of volume, and that volume exerts a pressure, aka auto PEEP. So now let's go back and look. Look at that. Auto PEEP of 1.4, right? Our total PEEP is now 6.4, not 5. We are air trapping. And if the patient breathes faster and faster, that's going to get even worse. Oh, now it's warning me. We're inverse ratio. Yeah, whatever. Anyway, you can see now we're not returning to baseline. It's even worse, right? Auto PEEP's now 2.7, right? Okay, so the patient is auto PEEPing. How do I fix it? Well, you can do the opposite of what I just did. You can drop the rate, you can drop the I time, or in some ventilators, you can also adjust like the IDE ratio, that kind of stuff. All of these three things are going to give your patient more time to exhale. So obviously, if we have the rate set really high, we can drop it, right? That will give our patient more time to exhale. Now we can see, oh, look at that, we're returning to baseline. See that? But let's say hypothetically, the patient is just breathing really fast for one reason or another. Maybe they're agitated, who knows? I don't know. Something's going on. And they're just breathing really fast. Well, what else can we do? Okay, well, we can decrease the I time a bit, right? Go down to 0.8. Let's see. That may or may not be enough to actually fully resolve it. No, not quite. But you can see that there's a difference in that gap now. The gap is lower, right? See, that will help. In reality, you should address why the patient is breathing fast, because you're not really going to be able to solve that auto PEEP. But those are the types of things you can do to try to help with that auto PEEP. Now, in volume control, we don't really worry about the inspiratory flow waveform. That's just not, But in pressure control, we pay a little more attention to that. I made a video on pressure control, so if you want to see what I'm talking about, you can go watch that video. But in volume control, inspiratory flow waveform, not really too worried about it. The other thing to look for here on your flow waveform is missed triggers. So I'm just going to lower the rate back down, just because. So if you see that we're sitting here at zero flow and you see little dips in it, but it's not triggering a breath, you have a problem with your trigger setting, right? That is missed triggers. Your patient is trying to draw a breath and they're not able to get it because it's not sensitive enough, right? Like if I have this set all the way up here, 20 is crazy. Could you imagine? The patient would be trying to pull a breath and not able to, basically. So the way you fix that is you adjust your trigger. Switch to a flow trigger if you're not already on one. If you're on pressure trigger, it's also harder for the patient to trigger. So switch to flow trigger first, and then turn the flow trigger down a bit more. Now, as for your pressure over time scaler, it can really show you two things. First of all, if you see a dip in the pressure during the inspiratory phase, that means your patient is trying to suck in more. They want more flow, more pressure. They are flow hungry. This is primarily a problem in volume control, and the way you fix this is by shortening the eye time or increasing the flow depending on what your ventilator is set to. Like this one lets you set eye time, so if I were to set it really high, let's set it ridiculously high just for dramatic effect. Look at how our current flow is like, I don't know, 30 something, 40-ish liters per minute. That's our flow. Now look, if I stretch out the eye time, look at that. Look how low our flow is. Our flow is like really, really low. Really, really low. Our peak pressure is dropped, but our flow is so low. Our patient, I'm telling you right now, is not going to like that. They are probably going to be flow hungry. That's not enough flow for them. So what you do is you reduce the eye time. Right? You bring it back down to something reasonable. And now, oh my god, my peak pressure is higher. My peak pressure is higher. Boo-hoo. Patient will actually get the flow they want. Now, the second thing the pressure waveform can tell you is what's called the stress index, which, once again, complex topic, not going to get into the details, but long story short, it gives you a quick and dirty idea if your patient is maybe over-distending or maybe needs a little more recruitment. But that's all I'm going to mention on that, and you really only see that in volume control. You're not going to see that in pressure control at all. You can't see the stress index there. And if I'm correct, you really only see it with a square waveform or constant flow. You're not going to see that if you have the decelerating flow. You're not going to see that. Finally, we have the volume waveform. Once again, this only tells you anything about an expiratory leak. If you see that this is not returning to baseline, if you see it's ending like over here and then the next one's coming down, then that means you have an expiratory leak of some kind. But you can also tell an expiratory leak based on comparing your VTI and your VTE. Obviously, those are going to be off as well. Once again, this is a simulator where, of course, it's exactly equal. Even in a perfect patient, it's never going to be exactly equal, but it should be close-ish. Now, the last thing that both pressure and flow waveforms can tell you about is if there's some kind of condensation or secretions. What you're going to see is you're going to see squiggly lines in either or pressure flow waveforms, possibly in both. And what you can also do is you could probably put your hand on the circuit and you might even feel it vibrate, just like you see those squiggly lines. Once again, this is either going to be condensation in the circuit or a buildup of secretions within the patient's airways. If it's caused by secretions, you're also going to have coarse breath sounds or rhonchi, and the squiggly line will be present throughout the whole breath cycle as well, inspiration and exhalation. If it's due to condensation in the inspiratory limb of the circuit, you're only going to see it on the inspiratory flow waveform. Then obviously, you assess your patient, you suction if needed, and see if the squiggles go away. Now, since we've talked a little bit about assessing data, let's talk about troubleshooting and what can go wrong. We've already talked about patient ventilator desynchrony in the form of flow starvation and missed triggers, but there's actually another one as well, which is called auto trigger, also known oftentimes as auto cycle. Now, I don't know if I can actually replicate this on this vent. I don't think it'll let me. It shouldn't. I don't think it will. No, because obviously this is just a simulation. It doesn't matter how I set things. It's not going to change anything. It's really just, it's a simulation. But what's happening is the vent is essentially triggering or cycling to inspiration by itself without any patient effort. This will be seen as an extremely high respiratory rate. Once again, I can't actually replicate auto trigger, but it would look, it's gonna look something like this. Like it's just gonna be trigger, 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 just over and over again, right? Can I silence this thing? I don't think so. Anyway, but it's gonna look like that. That's what's going on, right? You're gonna get, oh no, your minute volume is really high, right? Everything's messed up. Your rate might not actually be 60, but your rate's gonna be high, right? Clearly. Now you're gonna see that extremely high respiratory rate, almost like your patient is tachypneic, but the thing is, they're not gonna have increased work of breathing or other signs of distress like flow starvation. This can be caused by excessive condensation in the circuit, a leak in the circuit or the airway, a trigger setting that's too sensitive, or even by a strong pulse. Yes, cardiac movement can actually trigger the ventilator. So how do you fix it? Well, if it's condensation, get rid of it. If it's a leak, fix it. If it's a cardiac trigger or too high sensitivity, I would switch from a flow trigger to a pressure trigger, right? I would go over here, switch to a pressure trigger of like 2, and see if it goes away. Now, if it still appears to be triggering at a pressure trigger of 2, I would turn it up a little bit. I would turn it up to, say, like 5. Now, once again, if your patient's really, really frail, still might be a little hard to trigger on 5, but most of the time, your patient really still will be able to trigger at a level of 5. It's really not that much pressure. And if you are still seeing a really high rate, if it really still appears to be auto-triggering, it's probably not auto-trigger at that point. Your patient probably actually is in distress. So really, like, a pressure trigger of 2 to 5 should fix any kind of auto-trigger problems you have. So now let's talk about vent alarms and what can go wrong with that. So alarms. High pressure alarm is one of the most common alarms you're going to run across. And this indicates a high peak inspiratory pressure, which can be due to a number of things, but is almost always caused by some kind of an obstruction. This could be a problem with the ET tube, such as the patient is biting down on the tube, or a cuff herniation, or a kink in the tube. I would look at the patient to see if they're clamping down on the tube, and also try to attempt to pass the suction catheter down to see if there is an obstruction within the tubing. And if they are biting down, a bite block would work. And if there is an obstruction of the tube itself, it either needs to be repositioned or replaced. The obstruction could also be within the lungs itself, such as with a pneumothorax, bronchospasm, or retained secretions. I would auscultate to further determine the source of the problem, suction, or give a bronchodilator if I needed to. There could also be an obstruction within the ventilator circuit as well, so don't forget to look at your circuit too. Now, the other type of alarm you'll come across is the low pressure and low volume alarms. Now, low pressure alarms can be due to a patient disconnect, a leak within the circuit or ET tube cuff, or flow hunger. Low minute volume can also be due to disconnect, but can also be due to bradypnea in the context of a spontaneous breathing mode, or low tidal volume, either in spontaneous or PC modes as well. So that's pretty much it for today's video. Those are the major alarms you're going to come across. Those are kind of the starting settings you should have. Those are the things you should look at on the ventilator. And that should be a good way to kind of initially get comfortable with a ventilator. In future videos, I'm going to talk more about what adjustments you can make in each mode. I'm going to talk more about how each mode works and talk about obstructive and restrictive diseases and all those things. Different modes like APRV, PRVC. I'm going to talk about SIMV. But for now, this should be good to kind of give you the broad basics of what mode should I put them on, what settings should I put them on, what things do I look for on the ventilator, how do I fix the problems. Anyway, that's going to do it for today's video. I hope you all enjoyed, and tune in next time for the next one. Of course, I plan on making a lot of videos, but if you have specific preferences of what video you want next, please just let me know. And also, once again, this is the Hamilton Vent Trainer app on PC, on Android, on iOS. I'm not sponsored by this or anything, but I think it's a great teaching and learning visual tool. I think it's better than doing a PowerPoint for the whole thing, because you can kind of visually see what's going on. Of course, I can't replicate certain things. I can't replicate the secretions and that kind of stuff, but I can at least give you an idea of what's going on with the ventilator and how to actually control it. All right. Well, I hope you all have a nice day, and I'll see you next time.